Hello, this is a real pleasure to be here today for the first this new initiative of the International Academy of Clinical Hematology, that is the IACH Junior Club. As you know, the IACH activities are devoted to promote good clinical practice in the field of clinical hematology in order to educate, disseminate knowledge on accelerating cure of blood disease. Attracting the younger generations of new investigators in this field is of utmost importance at the IACH because this is about bringing new blood in our field and prepare the future. With this background, the new IACH Junior Club will bring together young colleagues from across the globe to cooperate, share experiences, and most importantly, put a special focus on the patient's first approach through discussions of real-life clinical cases. The goal of the IACH Junior Club initiative is to spotlight the work to our younger colleagues, students, residents, fellow registrars, assistants are doing every day to help those living with blood disease. Please share your more complex clinical case and discuss them with this new monthly case report forum by IACH Junior Clubs. We are counting on you, and we will have our first Junior Clubs today with two colleagues. We have Dr. Razan Mohty, that is a fellow of the Department of Blood and Marrow Transplantation and Cellular Immunotherapy at the Moffitt Cancer Centers, that is going to present a very exciting case. And we have Professor Gauthier, that is an assistant professor at the French Huntington Cancer Centers at the University of Washington in Seattle, and that is a real expert in the field of CAR T-cell that is here with us to discuss the case. So please, Dr. Mohty, if you can share your screen and present your case.
So first of all, thank you for this opportunity to present this case for the inaugural Junior Club. So I will be presenting a case of a patient who has HLH, or if we can say HLH-like syndrome after CAR T-cell therapy. These are my disclosure. So our patient is a 71-year-old man who has a past medical history of coronary artery disease, status post PTCA, and diabetes. He was diagnosed at an outside institution mid-2020 with multiple myeloma, IgG kappa, ISS stage 2 with FISH showing gain 1Q and monosomy 13. He received until late 2026 cycles of VRD and then was referred to us for autologous stem cell transplantation consideration. So as part of the workup of before transplant, PET-CT scan was done, and which was not done as a diagnosis, and showing, as you can see in this image, a large lobular mass in the spleen, around 9 centimeter, and he had another node next to the pancreas and another SMA lymph node. The PET scan also showed a right external iliac chain lymph node. So he had a biopsy of this right external iliac chain node, which showed T-cell rich large B-cell lymphoma, JC phenotype, and the immunophenotype was positive for PAX5 and CD20, and there was no evidence of plasma cells. FISH showed BCL2 rearrangement, so he didn't have any double hit or triple hit lymphoma. His IPI score was 4 because of the age, more than 60, poor performance status, and elevated LDH and the stage 3 disease. His CNS IPI score was intermediate risk. So he was started on R-CHOP as first-line therapy, and disease evaluation after 3 cycles was consistent with partial response. As you can see here, there was a decrease in the mass, but the SUV was still very high. During his course of treatment, it was complicated by cardiomyopathy with drop in his ejection fraction from 60% to 35%. He was seen by cardio-oncology, who optimized his cardiac treatment, and it was decided to change the anthracycline to etoposide. So he completed 2 other cycles of chemotherapy, and end of treatment repeat echo showed improvement of his EF to 55%. End of treatment PET was consistent with partial response. As you can see, there was decrease in the significant decrease in the mass, but it was still there. There wasn't any other site of tumor, so it was decided to deliver consolidative radiation therapy to the residual lesion in the spleen. After radiation therapy, the patient had another PET scan, which showed, in fact, progressive disease. And it was like several weeks after the radiation therapy, so less likely to be inflammation. And he had an additional new lesion in the lungs, which was biopsied, confirming the presence of relapse progressive disease. He received salvage RG-MOX. Disease evaluation after RG-MOX showed persistent disease. And here it was like end of 2021, CAR-T was not approved at second line, so that's why he's progressed for salvage chemotherapy. He was referred after failure of second line for CAR-T cell therapy. He was planned to receive lisocabtagene maraleucel. He received lymphodepletion, fludarabine cyclophosphamide, no complication during the lymphodepletion therapy, and he was admitted on day -1. On day +3, he developed fever, 39 degrees. Infectious workup was done, treatments were initiated. He received cefepime, and he had decrease in the blood pressure afterwards, so a grade 2 CRS was diagnosed, and he received the first dose of tocilizumab on day +3. Persistent fever, persistent CRS on day +4, he received another dose of tocilizumab, and day +5 for persistent CRS, dexamethasone was started, and tocilizumab dose 3 was delivered. On day +7, patients started to have decrease in his I-score, 7 out of 10, and then to 1 out of 10. His ICANN was grade 3. He was transferred to ICU. Workup was done. MRI brain was negative. EEG showed generalized encephalopathy. LP was positive for Haemophilus influenza. ID team were consulted, and they thought this is like incidental finding. It was treated with Rosifin. He was on Vimpat or lucazamide. Dexamethasone was continued, but he was given, but he was continued on methylprednisolone because of his mineralocorticoid effect, and he was having labile blood pressure. On day +8, his ICANS, his I-score was 9 out of 10. His ICANS improved, and he was started to have grade 1 transaminitis. He continued on same dose methylprednisolone. On day +14, he was still improving. Still, ICANS was 9 out of 10. He was continuing on the seizure prophylaxis, and his methylprednisolone was decreased to 250 twice daily because of improvement. You can see here the ferritin level, it was not really very high, peaking at 1,000. On day +17, patient continued to be on methylprednisolone, but he has a acute rise in his LFTs. So his ALT increased to 2,100, and his AST was 1,100. Ferritin peaked at 3,800. Bilirubin increased. His D-dimer was 30,000, and cytokine panel showed increased IL-6 and IL-2. Methylprednisolone was increased again to 500 twice daily, and he was started on anakinra twice daily, and rasburicase was given once because of increased uric acid. On day +19, bone marrow was done, which was, so the initial report done by the pathologist showed that there is some picture of HLH, and then the final report after discussion with other pathologists, they didn't really mention that this is HLH, so they cannot call it HLH. Methylprednisolone was continued, anakinra was continued, and he received another dose of ciltuximab. On day +20, LFTs started trending down. On day 26, I'll show you the numbers in the next slides. He continued to improve. Prednisolone was tapered, and he continued on anakinra for 5 days. This is the picture. This is during the CRS. This is the CRP decreasing, the LFTs peaking, and so this is the highest bilirubin at 3.6. As you can see, the ALT peaked at 3,400, the AST peaked at 1,600. So this is the picture during the HLH-like. The ferritin didn't really increase, so this is during the HLH-like episode, peaked at 3,800. He was on steroids during that time. So this is our case. The patient ended up improving. His LFT is normalized, his bilirubin normalized. He was discharged on prednisone equivalent, and he continued to improve, and he's currently doing well and in remission. So I have a few slides to talk about what is HLH. So this is HLH as sidecar T. HLH is usually secondary in most cases. It's life-threatening. It could be secondary to infection, autoimmune diseases, or hematologic malignancies. So usually we have a panel of criteria to diagnose the HLH, and most of the patients should have that. And this is outside CAR-T again. So usually patient might have 5 out of 8, fever, splenomegaly, cytopenias, hypertriglyceridemias, hemophagocytosis in the bone marrow, low or absence NK cell activity, elevated IL-2, and ferritin more than 500. Sorry, 500. So these are the diagnostic criteria published by Nilapu et al., trying to categorize or like to put a diagnosis criteria for patients with HLH after CAR-T. So they mentioned that the patient should have a peak of ferritin level more than 10,000 during the cytokine release syndrome phase of CAR-T, and having one of these criteria. So having grade 3 increase in bilirubin or any of the LFTs, grade 3 oliguria, or having elevated creatinine levels, grade 3 pulmonary edema, and presence of hemophagocytosis in the bone marrow. This is their algorithm in the paper, again by Nilapu et al. So any suspected HLH, manage grade 3 toxicity with anti-IL-6 and corticosteroids, monitor blood ferritin, LDH, fibrinogen, transaminases, bilirubin, creatinine levels. If not improving, then continue managing per CLS algorithm. If no, then consider adding etoposide, knowing that etoposide can affect or kill the CAR-T cells. So my questions are, so is it really HLH, or this is like a severe inflammatory form of CRS? What are the diagnostic criteria? So most of our patients will have prior CRS, ICANS. They are already on steroids. So do we really need a cutoff of the ferritin to reach 10,000 to diagnose this HLH? What is the optimal treatment? What type of steroids? So some might say, so dexamethasone is the best. We cannot shift until the patient is really improving. What's the optimal dose of anakinra? There's lots of published studies with different doses, duration, and when it's safe to stop the therapy. Some might transition outpatient anakinra. What's the role of other monoclonal antibodies? So our patient received cetuximab. Is it really effective in this case? And what's the role of prophylactic anakinra? So there is some studies and an ASH abstracts last year assessing the role of using prophylactic anakinra in patients who are high risk to develop severe inflammatory syndrome. And thank you.
Sorry, Dr. Mohty, for this very interesting case. And yeah, it raises a lot of questions. And by the way, for all the attending, do not hesitate to send your question through the chat so we can ask them to Dr. Mohty and Professor Gauthier. And my first question will be for you, Professor Gauthier. What is your first feeling regarding this case? Have you already seen this kind of situations when this is difficult to diagnose between the cytokine release syndromes and this HLH? You will have done the same thing in the same case?
I mute myself. And so my first impression is that I was worried the patient would do very poorly, and because usually these cases are don't end up very well. So I was happy that this patient actually improved and also had a good response, it seems. So I was surprised by this, because the first thing I kind of picked upon was that this is a patient with a fairly rare and unusual subtype of LBCL, right? He was a T-cell rich lymphoma. We know that we don't have a lot of experience with T-cell rich or T-cell histiocyte rich lymphoma, and it looks from the few case series that this patient don't tend to respond very well to CD19 CAR T-cell therapy. If you actually look at there's not a lot of data about CAR HLH in the literature, but if you look at the experience from Madrid, there's actually one case of a patient who does have T-cell rich large B-cell lymphoma. So that's sort of the first thing that I've noticed. But I was not expecting this patient to be actually in response. So that was my first impression. In terms of, so there's a lot of things we can unpack from the case, but in our experience, we don't see a lot of CAR HLH. But as you rightly mentioned, there's a huge overlap. And is this really HLH as we sometimes see it, with the caveat that HLH, secondary HLH, is so heterogeneous. We see it in a lot of hematologic malignancies. And every time I see a patient, it looks like it's always a slightly different picture. I don't know what you guys' impressions are, but that's my feeling. Is it's a very poorly defined entity. And it is basically there is uncontrolled T-cell or CAR T-cell activation and monocytic activation happening in the context here of CAR T-cell expansion and activation. We tend to give dexamethasone early on. Usually this patient would have received, with his first dose of TOSI, 2 doses of dexamethasone. That's our standard practice from our experience with defined composition products from clinical trials. And using this could have, I don't think it would have maybe changed everything, but maybe we would have started steroids early on, which may have impacted the patient's course. So I'm going to stop here.
Thank you. You already answered some of the question in the chat about your feeling if this is some severe case of CRS of more really traditional HLH. On this raise all the difficulty to of the diagnosis between the two entities. In fact, the HLH is not really clearly defined. There is this proposal for the definitions, and this is why Dr. Mohty raised of the question of the ferritin level as a cutoff, but this is very artificial, and also of the diagnosis of criteria. But in fact, we know that we have also some HLH diagnosis criteria, not in CAR T-cell, but in other setting, and maybe it could be one of the ways just to use the classic diagnostic criteria for the HLH. That could be the good way to diagnose the HLH even in the setting of CAR T-cells. I don't know, what do you think, Dr. Mohty?
Yeah, so I think that this could be like a distinct entity after CAR T. Maybe it's not really the full-blown HLH, not the CRS, but this is like, I'm not the expert in this, but this could be characterized and could be more studied more. There is some studies that are published trying to understand more this entity, and several called it, like, this is not me who called it HLH-like. There is several publications trying to characterize what is like this severe inflammatory syndrome. And I think that this cutoff of 10,000 is very much high, and it's arbitrary, as you said. Several patients are already on several dexamethasone, receive tocilizumab, and this ferritin might not go as high to 10,000. It's a clinical judgment for now, no criteria to diagnose that after CAR T.
Yeah, probably what we should do also always in these patients when we suspect this kind of thing, this is to look also to perform the bone marrow assessment, because I think if we have some hemophagocytosis on the bone marrow assessment, this is also important, and we don't see that only in a cytokine release syndrome. So it's a good thing to assess this. So we have some more questions that go through the chat. One of them is regarding the question around anakinra. This is a key question regarding when we should use it, what is the right doses. And she said, yes, should we have used anakinra earlier when the patient has cytokine release syndromes? You use 3 days of tocilizumab on steroids on the 3rd dose. Should you have used anakinra at that time point, and maybe we would have prevented the onset of the ICANS and also of the HLH? I don't know, Professor Gauthier, what is your feeling? Did you use anakinra also for the treatment of cytokine release syndromes if tocilizumab is not effective?
So in our experience, it's very uncommon that we see refractory CRS, especially after lysocell treatment. It's extremely unusual. Maybe because we used dexamethasone early on as frontline as well. We tend to use anakinra for patients with either refractory or prolonged ICANS, so neurologic toxicity. So that's usually the pattern. CRS, we can treat it. Usually CRS symptoms go away. And then we have ICANS coming in, and patients are on high dose of steroids for a few days. And despite this, as they are on high dose steroids, they keep getting worse. And then that's usually when we pull the trigger for high dose anakinra. And I noticed the dose of anakinra used in this case was quite low. So we don't know in the context of ICANS how good the penetration of anakinra is into the CSF and the CNS. It could be higher because of blood-brain barrier damage or increased permeability. But we know that anakinra, from a lot of studies from the 90s, has very low CNS penetration. So if there is no more systemic inflammation, and what we want is really push that anakinra in the CNS, we probably want to go much higher. And at our institution and others, we tend to use 8 to 10 milligram per kilo per day, which usually runs up to 200, 300 milligram every 8 hours. So we tend to use that, and that's usually in the context of ICANS, and HLH. We don't see it very often, but I would probably use the same approach initially. And I think as soon as we see that steroids are not cutting it, because the other issue is going to be, steroids-induced side effects and risk of infections and so on. So usually we would quite early start the high-dose anakinra and try to use that as a steroid-sparing approach to get the patient off steroids as early as possible.
Yeah, to decrease the steroids. On how long are you going to keep the anakinra?
So there's no magical duration. It's really based on clinical symptoms. As soon as the patient is clinically improved, we would consider first tapering the steroids, and then usually rapidly tapering the anakinra. But again, with the rationale that as soon as you decrease your anakinra, there's probably extremely limited CNS penetration. If you're treating ICANS, of course, if you're treating HLH, you will look at your different HLH features, maybe the ferritin, and other liver function tests, your triglycerides, and so on to base that decision. So it's really based on clinical and biological markers.
Yeah. I agree with you. We have a very similar approach when we start with the ICANS, with the high-dose steroids, and very quickly after we go to the anakinra if we don't have any improvement on decrease the steroids. So just good to see that we have some similar approaches in this kind of patients. And what you just said bring me to the one question by Matthias Wolf that asked me, yes, so we have to monitor the treatment according to the patient's symptoms, but in fact, in some patients, the fevers, organ toxicity on the markers may respond very differently. And how are you going just to manage the cytokine blockade? For example, if there is still some fever, but the CRP on IL-6 level go down, because does it make sense to just give some cytokine blockade if we have very low CRP on IL-6 level, but still some fever? What are you going to do? I think this is more a question for the cytokine release syndromes.
So one point I can make here is that I think so far we've seen the HLH described by the NIH group, which is Dr. Niralisha, and she's reported this very nice characterization of HLH in this setting, which may be a little bit different from other HLH that we see with other products, not targeting CD22 and not using a fixed, so a defined composition product, or in their case, they're doing a different manufacturing. Having said that, it looks like in the CD22 targeted setting, the IL-6 is actually not really a good marker and actually seems to be trending down, as the other more HLH-related cytokines are sort of skyrocketing along with ferritin, and they actually used a cutoff of 100,000, I think, on that trial. So again, it's maybe a bit of a different entity compared to what we are seeing here with Lysocell, which is targeting CD19. So that's what I can say. And so I think the big answer is that we don't really know. I think if IL-6 is trending down and is low, I don't think I would use siltuximab. In this case, I think he was still trending up or still was elevated, so I think it was perhaps reasonable to use it.
So I would just go back to you, Razan. I have one colleague, Ezra Gulderen, that asks you, for example, if you have some patients that have some severe toxicity with CAR T cells, but at the fact the toxicity result, for example, if you present some HLH or cytokine release syndrome that is severe, and the CAR T cell at the end was successful, but there is some disease relapse 6 months later. You have the possibility, for example, for this patient to have a second CAR T cell product. Are you going to give the patient a second CAR T cell product because she presented some severe toxicity with the first treatment, or you say no, we'll not use anymore some CAR T cell in these patients, and we need to use other treatments?
Actually, we have several options to mitigate toxicities, and if patient is predicted to have several toxicities, and using prophylactic treatments. For instance, we have data on using the prophylactic dexamethasone with axi-cel from the cohort 6 of ZUMA-1. So we have this data. Patients had really decreased toxicity after CAR-T, and there is also studies on using prophylactic anakinra. So there is some ways to prevent toxicities, and we can still use another product with prophylactic treatment.
Thank you, Razan. On you, Jordan, did you have any experiment for some patient that received twice some CAR T cells and that have some severe toxicity with the first one, and the tolerate one, the second one, or?
So we are experienced with second infusions. Overall, we saw actually less toxicity the second time because we saw less in vivo expansion and activation of CAR T cells, and also lower efficacy. So that's not really the major concern as we retreat patients, but that was in quite a specific setting that was on a clinical trial. And we have anecdotal cases where we retreated patients with commercial products later on, maybe the first time they had an investigational product and we retreated. I don't think this is necessarily something we would consider as a deal breaker not to give a second infusion, but giving second infusions can, in what context is it done? Is usually done on a clinical trial at this stage, or in a patient who've already received an investigational product and now is getting a commercial product. So the situation is still very uncommon in our experience. So a bit hard to tell what to do there.
No bad safety profile with a few patients. It's more about regarding the response that maybe it's not less effective with the second. So we have to discuss some other treatment, but only that to be in clinical trial mainly. But still, it is interesting to have your feedback on these few patients. Somebody asked me in the chat if you have any experience regarding ruxolitinib for T-cell blockade in patients with severe cytokine release syndromes.
Razan, do you?
No, actually, I don't have any. I've never seen using it, so I don't have any experience with that.
So we don't have at the Fred Hutch experience with it. An issue is that it would be insurance clearance in the US, particularly when patients are inpatient. It can be quite challenging to get this type of targeted agent cleared, especially in a sort of emergency setting like that. So with the data we have so far, as the audience is probably aware, is from the NIH. Again, in the CD22, I think there were some, and maybe a few patients from St. Jude as well, who received ruxolitinib, really a handful of cases, and a bit unclear whether it really provided a benefit or if it's just the toxicities subsiding, resolving on the road.
So yeah,
but people have tried it.
Yeah, people have tried it, but so far we don't have also any experience in Paris here. So we are going very close to the end of this very exciting first IACH Junior Clubs. Razan, Jordan, do you have a last comments regarding this case?
Yeah. So I think all my questions were answered. Thank you, Dr. Gauthier. So I think that in these cases, it's the spectrum of high inflammatory syndrome, CRS, and HLH might overlap. And nowadays we're using more and more steroids, more more early on in the course of CRS. My question to Dr. Gauthier would be like the type of, I've heard from some physicians talking about not shifting from dexamethasone early on to other types of steroids because of the penetration of the dexamethasone more effective in ICANS. So what does he think about using like methylprednisolone? Is this can be effective in that case, or when do you shift to oral prednisolone?
All right, so a few things. I think historically, and I think that the data is actually not the best, but dexamethasone has the highest CNS penetration. I think that's what initially we were using it. But then we really crank up the dose, like the case showed, going up to 1 gram per day for a couple of days. So we usually, that's what we usually do, right? IV dex, then switching to IV methylpred, very high dose, 1 gram. We don't split it. We just give it a gram at a time. And then it's so much steroid. It's rare that we would do a very slow taper going back to maybe oral pred, or we usually don't do that. If the patient is actually having progressive symptoms of steroids, we would go back to dex. So that's usually what we would do. I know we are kind of going over time here. One thing that I wanted to mention is that when these kind of cases happen, my two big concerns are ruling out a viral trigger, so making sure there's no CMV reactivation, EBV reactivation, or something else. In this case, there was a Haemophilus influenza. We didn't know how to factor that into the situation, but oftentimes we are going to find a viral trigger. The second thing, making sure the patient doesn't have refractory disease. The few cases that we had just, they were not in response, and they had this sort of uncontrolled T-cell and CAR T-cell activation. So really obsessively making sure your patient doesn't have refractory disease and a viral reactivation or infection going on at the same time.
So thank you again, Dr. Mohty, Professor Gauthier. It was very exciting clinical case presentation with a lot of questions, from the audience. So everybody now is very welcome. If you want to send an email with some clinical case proposal you want to present during this IACH Journal Club, you are welcome. You can send the email to clinical hematology IACH info. And the next presentation will be in November, and I am sure that you will be a lot of people again for this very exciting presentation next month. Thank you very much.
Thank you.